I've been asked to talk about some drug diversion issues and what we do at the practice here for an FDD practice. You have to remember that these are postulated and dependent on what state you live in, all right, we're in California. And bottom line, back in a couple of years ago in February, our local DEA sent out a circular, essentially a letter to all the doctors recommending some recommendations for prescribing narcotics, of which, between you and me, most doctors are in the circular waste basket. Nothing happened. And this is because of this marked incidence and increase in narcotics deaths, especially back east, and it's just terrible what's happening. Anyhow, so nothing happened. So then what happened then is 2 years ago in May, Department of Justice and the Medical Board of California got together and essentially set up a plan whereby if doctors are negligent in prescribing narcotics and do not follow these recommendations that are done, essentially they can be brought up. If a patient dies with a narcotic on board complicatory to that death, the doctor loses his license and goes up for manslaughter. Still nothing happened. And then June of that year, the first doctor in LA lost her license and went to prison for, I think, a sentence of 16 years, but whatever. And immediately across the board, most of the doctors quit prescribing narcotics and sent everybody to the pain clinics. We did not in the practice for several reasons. Number one is that we have a fairly good program. I want to sort of outline what we do. Number one is every patient that is on a scheduled drug has to join Tier 3, which means they have to be involved in active counseling. And every patient who gets a scheduled drug has to come in for every 3 months for a counseling appointment. Most of these cases, they're short counseling appointments, everything's going well, it's stable, no problems, end of discussion, all right? Now, whatever the counselor says, if they have to come in every week, they have to come in every week or they don't get their scheduled drugs. And most, it's okay, but if that appointment gives us time to pick out alert signals and problems or issues that there are problems and go into them deeper so that these patients don't get in trouble. Number two, many of these patients are dependent but not addicted. And it's easier when you have time to look at those things to realize when these people are getting addicted versus dependent. Because whether we like it or not, many of these people are controlled dependency issues, and some of them even controlled addiction issues. Number two, we have a formula of unannounced, let's say the month of September or November, whatever we're going to do, we drug screen all our patients. And the patients are kind of confused. They think we drug screen to make sure that there's no other drugs on board, and that is true. We look for, you can't be on cannabis or this or whatever, or other, cocaine or anything, or else you don't get your drugs, all right, your scheduled drugs. But more important than that is we want to make sure that they do, let's say they're getting a narcotic on board, we want to make sure that narcotic is being represented in that drug screen. Because if it's not, there's a diversion issue, all right? And number one, it's not that often, but this is how we usually catch these people, all right? They're diverting or they're selling or doing whatever, all right? So that solves the issue of diversion, all right? Because we are not interested, and it's possible for these patients to get their scheduled Percocet or their Norco or Vicodin or whatever it is, and then sell it in the street, and they'll make money off us, all right? We are very attuned to that, and we watch, and we'll drug screen even ahead of time if we think there's an issue there. And what we look for is a patient who's on their narcotics, and they have no narcotics in the drug screen, red flags go up, and it has to be dealt with and addressed why and what's happening.